welcome. Tonight, PKD Charity are hosting a live session, kidney transplant in PKD. So it's lovely to have so many of you join us tonight. I'll do a brief introduction of those who are on the call from our team and obviously our guest speaker. So you may be aware of myself. I'm the support manager at PKD Charity. I'm Susan Muirhead. I must update that picture now that my hair's a bit longer. It's great to have you. If you have any queries at all, you will have my email address now with it. Please feel free to drop me a message. I'm joined tonight by Jane Pugh, again, many of you know from Communications and Events. She's going to be co-hosting with me. And we've also got Audrey Hughes, our Patient Involvement Engagement Officer, who's going to be looking at many things in the upcoming months regarding research. So Audrey's going to be sitting behind the scenes tonight. So we've also got the main gentleman, our main guest speaker tonight, Mr. Hussein Khambalia. Hussein is fantastic and has given his time previously so willingly and free to PKD Charity on many occasions. We do very much appreciate that. For those who have never heard Hussein speak, he is a general consultant and transplant surgeon at Manchester Centre for Transplantation. So I don't know, you might well have come across him if you've been on the table and you've had a transplant previously. So welcome to tonight. We have to obviously give a medical disclaimer. By no means is this meeting personalised information. It's general purpose only, and it doesn't replace the guidance from your own team or a medical examination. There may be things discussed in it, or perhaps responding to a question that might vary slightly from your own situation. So please always consult with your doctor, your pharmacist, or another medical professional. And we do never ever recommend or promote any brands or specific treatments. We've all become more familiar with Zoom, but some of you might not use it on a regular basis. So here's just a little reminder on how you can ask questions. Some of you have asked questions in advance, and a great many of them will be covered in our session tonight. But if you wish to ask one perhaps at the end, you can pop in to the chat button, which you'll see in a circle there, using the chat facility and type your question in. A member of our staff or team can ask that on your behalf. If you're feeling a little bit braver, you can hold your hand up and we can come to you on camera and you can ask your question as a verbal thing. Do remember it is recorded and will be published to YouTube. So if you want to have some privacy, perhaps just do it in the chat box. And always, while we're speaking, please, if possible, go on to muted. So we also then look there at introducing Hussein. So I will hand over to you. So I'll stop my screen share and hand over. Okay.
There we go. Thank you, Susan. Can you hear me? Can you see that screen?
Yes, perfect. Lovely. And I'll put myself on mute.
So, thank you to Susan. Thank you to the team at PKD for asking me to speak this evening. It's always a pleasure and I do enjoy this talk. So without further ado, as Susan said, if you have got questions, please feel free to ask them at the end. If there's anything that you want clarification on as I speak, then do ask. And I'm happy to go through things if need be, okay, as we go through. But what I hope to do today, this evening, is give you a brief overview of essentially the road to transplant, what's involved in terms of getting to transplant, how we manage patients through the transplant process, and there are photos at the end of a transplant procedure where I go to in a bit more detail with some photos about what we do during the transplant. So a bit of a disclaimer there as well. And that disclaimer will come up before we show any more photos about it. Okay. Now, I know there's a wide variety of people on the call. There'll be patients, there'll be family and friends and relatives. And some of you will know a lot about ADPKD, and some of you may not know as much. So I'm starting really, hopefully get everyone a bit of information and knowledge about what polycystic kidney disease is. And really, if you look at the two photos or the two pictures on the right, a normal kidney is about the size of your fist. And in polycystic kidney disease, the kidney size can increase hugely. A normal kidney is about 10 to 12 centimeters long, and a polycystic kidney can be 30 to 40 centimeters long. So a huge increase in the kidney size because of something called cysts. And cysts are fluid-filled cavities within the kidney that essentially take up the kidney and end up taking up so much of the kidney that the kidney fails and stops working. And that's at that point when you need a transplant. It's a genetic condition that can therefore be passed on from one generation to the other. It's incredibly common in the UK, actually, and it's the 5th most common cause of end-stage renal failure in the UK. And as I said, because it's genetic, it's commonly inherited. So people know family members that have got it and are often screened for it themselves when they get into their 20s and 30s. So polycystic kidney disease causes a number of problems associated with the kidney themselves and also other parts of the body. Those specific to the kidney relate to pain because these cysts can rupture or burst, or they can bleed into the cysts, and that they can cause pain from any complications of specific cysts. Patients with polycystic kidney disease are more prone to urinary tract infections, so water infections. So you can get repeated UTIs and water infections needing antibiotics. Occasionally, the cysts themselves can get infected, and that can be a bit more difficult to treat because you then have a cavity within a kidney that becomes infected, and that's more difficult to treat than a simple water infection. I've said bleeding into cysts, that not only causes pain, but it can cause a reasonable amount of blood loss. And sometimes patients are admitted because their blood levels are quite low because they've bled into cysts. Said the cysts can become infected. Patients are more prone to kidney stones. They can cause pain, blockage of the urine from the kidney, and bleeding as well. That can cause bleeding from the urine. And in the longer term, you can develop kidney failure, and that's why you would see someone like me who's a transplant surgeon. In addition, they can cause pressure symptoms, and when kidneys become very, very large, you can imagine that if you've got two kidneys in your tummy and they're both 30, 40 centimeters big, and the volume of them becomes very, very big, so they can cause pressure symptoms, so pain, discomfort, and problems with absorption and eating and drinking. Okay, issues related to everything else. So it can cause high blood pressure. High blood pressure is very closely related to kidney failure anyway, so it's very, very common. It can cause abdominal bloating and discomfort just because of the size of the kidneys and the amount of space they take within the tummy. We think part of polycystic kidney disease is a problem with connective tissue, and that can cause problems with some of your blood vessels, specifically the ones in your brain. So you can develop aneurysms within the brain that might bleed. An aneurysm is a dilation of one of the blood vessels. Again, because of the connective tissue problems, you can develop hernias, which are essentially weaknesses in the tummy wall, which can present as hernias, and problems with the valves within your heart. Diverticulosis is an outpouching of your bowel that can then become infected and can cause problems. And patients with polycystic kidney disease are more prone to diabetes. So it can cause a wide range of other problems that patients have to deal with, in addition to the specific kidney problems that we've been through. So because of these huge number of problems that polycystic kidney disease can cause, the management of polycystic kidney disease isn't as simple as just treating the kidney disease or just giving a transplant. And we try and manage patients based on everything else to try and minimize the risk of things getting worse. And that includes things like diet and generally eating healthily, exercising, managing the diabetes and keeping blood sugar under best control. Obviously, stopping smoking reduces your risk factor of things like blood pressure and peripheral vascular disease and heart attacks and strokes and things. Hydration is incredibly important because a lot of the time with kidney failure, you can stop producing urine, but actually a lot of polycystic kidney disease patients continue to produce a lot of urine, even when the kidneys have stopped functioning. So hydration and fluid balance is very important. And there are specific medications, and tolvaptan is one of them, that can manage polycystic kidney disease specifically. I'm not going to talk any more about tolvaptan. That's a topic in itself. But it's something that if you are suitable and if it's available, then your nephrologist, your kidney doctors will speak to you about that. So renal failure progression is defined as 5 stages, stage 1 to stage 5. And stage 1 is essentially normal function, where your kidney function is greater than 90%. And then stage 4, which is at this point, is where you've got severe loss of function. And this is where you would be referred to our transplant services and or for dialysis should you need it. At kidney function of less than 15%, you'd be able to go on the kidney transplant waiting list, and much lower than that. And that's when the nephrologist would start to look at dialysis for you. So we would see you at stage 4 renal failure. Briefly mention dialysis, and I'll speak about it very briefly because that's another point where you might come in contact with a transplant team, depending on where you are in the country and what the services are like in that country and who deals with them. Then you may see members of the transplant team. So in Manchester, where I'm based, we would offer any patients going on dialysis access for dialysis as part of the transplant work that we provide. So that would include insertion of peritoneal dialysis catheters if you wish to have peritoneal dialysis, and creation of fistulas should you wish to have hemodialysis. Now, in terms of the benefits for transplant, there are a huge number of benefits, and most importantly, they improve your quality of life compared to dialysis. They improve your life expectancy, and they're the 2 main reasons that we would offer a transplant to somebody who's fit enough for it. They obviously reduce your dialysis-related complications, and dialysis can lead to a huge number of complications with blood pressure management, fluid management, problems with the heart, problems with circulation. And stopping dialysis for a transplant would reduce these complications. In children, they improve growth and development drastically. So the earlier you can transplant a child, the better. And they're also cost effective for the healthcare system. So dialysis is much, much more expensive than a transplant itself. This does, however, come with a number of complications of transplant, and these are not in their entirety, but I'll go through some of the main ones. Those specific to transplant. In transplant, we are joining the kidney to some of the bigger blood vessels in your body, so that while doing that join and in the recovery period, there is always the risk of bleeding. About 1% of patients have to be taken back to theatre to have the bleeding stopped. So it's not very common, but it can happen. One of the most common complications after any operation is infection. We always give antibiotics prior to transplant to try and reduce the risk of infection. But especially with surgery, and especially in transplant surgery, you are at risk of infections, commonly in your wound, your urine, or your chest. I always say to patients, the best thing you can do to prevent an infection is to try and get up and out of hospital as quickly as possible, because that means you're up and about, you're using your lungs properly, you're moving around, and you're out of hospital and back home, which is where you're at lowest risk of getting an infection. Urinary complications. So where we join the kidney to the bladder, we put some stitches into the ureter where the urine comes from and out into the bladder. There's always a risk that that joint can leak in the short term, and you may need another operation to fix that. Or there's a risk that in the long term, that joint can narrow down. So you may need further procedures to just widen that up and allow better flow of urine out from the kidney. As I said, we join the kidney to some of the big blood vessels in your body, and occasionally that blood can stop flowing, and that's called a thrombosis, and that can happen either to the blood bringing kidney, the vessel bringing blood into the kidney, or taking blood out. So either one of those vessels can stop flowing. If that happens, it's normally within the first few days within the transplant, and that would mean that the kidney has to be removed, so you'd lose that graft. Rejection is something that most people having a transplant worry about, and for good reason. The risk of that overall is about 10% within the first 6 months. The anti-rejection medicines now are normally very, very good and very, very effective. So it doesn't always mean you lose the kidney if you have a rejection. More often than not, you'd come back into hospital and have some stronger anti-rejection medicines to treat it. And most patients go home with a good working kidney afterwards. One of the most common complications after a transplant is something called delayed graft function, or a sleepy kidney. And in deceased donation, the risk of that is about 50%, so very, very common. Essentially, the kidney doesn't like being taken out of somebody, being put in an ice box, and then being put in somebody else. So it gets stunned and goes to sleep for a while. So normally that takes a few days, occasionally a few weeks to recover from. But most of the time, that recovers with good kidney function. Very, very rarely, and we quote about a 1% risk that it doesn't work at all, and that would be called a primary non-function. Quite often we may not know why that occurs, okay, but that can happen. It's very rare. We have to be honest, and not everybody survives the kidney transplant procedure. Saying that, we know that about 95% of patients at 1 year will have a good working kidney. Okay, so the outcomes are very good. And if you get to that stage, then you are worked up very, very closely to make sure that not only could you withstand the transplant, but then the recovery as well. Okay, the complications specific to immunosuppression. So transplant is not a silver bullet and is not the cure that we wish it was, because you're trading dialysis with not just the risks of surgery, but lifetime risks of immunosuppression. And these are drugs that reduce your immune system and reduce the risk of you having a rejection. In the long term, the risks of these drugs are that they make you more prone to infections. They can make you more prone to specific cancers, not cancers in general, but specific ones. And they make you more prone to getting diabetes. Okay, we monitor these, and we are aware of these, so we do monitor them as outpatients in every transplant recipient. There are, of course, extremely rare complications in deceased donation. It is very, very rare, but it does happen, where we can transmit infection or cancer from the donor. The donors are thoroughly worked up in detail, but there's always something that we could potentially miss, because we don't have a long time to work up the donors because of the logistics. So there's a very small chance that we can miss something, and that can infect the kidney. And with any major surgery, there's always a risk that we can damage some of the surrounding structures while we're operating. But thankfully, that risk is very small. Okay, on to more positive things. So the path to transplantation. As I said, you'll tend to be referred for transplant at around stage 4 kidney failure. Your nephrologist, who's your kidney specialist, will identify what stage of kidney failure you're on. They will work you up and do a number of the investigations that we require before sending you to see us. So we should see you with a whole pack of information, your history, and a lot of investigations looking at your blood tests, your tissue type, to make sure that your heart and lungs are fit enough to undergo a transplant. And we will assess you. And at that point, there's a number of outcomes, but essentially, we could either be happy and say, yes, you qualify for a transplant and we think you're fit enough and you'll benefit from a transplant, in which case you go on the waiting list immediately. Or there may be some more information that we need, or some more tests that we do. We may need to discuss your case at our multidisciplinary team meeting. And that is essentially a meeting where people from various specialties, so kidney doctors, transplant surgeons, specialist nurses, sometimes anaesthetists, and anyone else that may be pertinent to your care, may discuss one, whether you would benefit from a transplant, whether you'd be fit enough for a transplant, and whether there's anything we can do prior to listing you that would get you in a better physical shape to get you ready for transplant. And then when you're on the waiting list, if it's a deceased donor waiting list, you'd wait for the call and hopefully come in one day and get your transplant. So what's the criteria for transplant? It's really quite basic when you look at it. The criteria are patients that are currently on renal replacement therapy, so currently on dialysis, or those that are predicted to be on dialysis within 6 months. Now, it's incredibly difficult to predict who will exactly be on dialysis within 6 months, but we define that as having a GFR or a kidney function less than 15. So one of those two categories, and of course, fit for transplant. So in terms of transplant assessment, and this is done initially, as I said, by the nephrologist and then by the transplant surgical team. It's to identify patients who initially want a transplant, and that may seem obvious to a lot of people, but there are occasionally some patients who don't want a transplant. Those who will benefit from transplant, and I think the vast majority of patients that I see will benefit, but we are very aware that a number of patients have been looked at by the nephrologists and made the decision that they probably wouldn't benefit from a transplant because their risks are too high and therefore not sent to us. So those that fit the criteria for transplant, which I've just mentioned, those that would survive the peri-transplant process, and we do everything possible in order to ensure we identify the best possible candidates and the fittest possible candidates, while keeping the doors open to transplant for patients that want it. And those that will comply with transplant follow-up. As I said, transplant isn't the silver bullet that we aim for one day. It is intensive follow-up. It does require regular visits to hospital. It requires compliance with medication, and patients have to be able to follow that. And most do. That doesn't often cause a problem. So in terms of transplant assessment, in the top left corner, we've got the nephrologists and the nephrology specialist nurses and the pre-dialysis team. In the top right, it's the transplant team. So it's not just the surgeons, but the specialist nurses. We've got a live donor team, should you wish to go for a live donor transplant, and the transplant lab, because they're pivotal in identifying immunological risks, so risks of potential rejection, and finding suitable donors for suitable recipients. And we rely, certainly in Manchester, very heavily on our anaesthetic and preoperative team to identify patients who may be at higher risk or those that need extra workup prior to transplant. And at the centre, of course, the patient and the relatives and carers. When we see patients, we take a full medical history. Often a lot of this will be sent to us, but we ensure that what we've got is correct and that there's not been any changes. So obviously a cause of the kidney disease, a full dialysis history with any admissions to intensive care, previous surgery, and previous sensitizing events. So these are events that may cause you to have antibodies and may make matching of potential recipient donors harder. And these are caused by blood transfusions, previous transplants, and pregnancies. We want to know about any other illnesses that you may have, any family history, specifically of kidney disease, such as polycystic kidney disease, of course, social history, and medications. It's incredibly important, obviously, that we examine the tummy of any patients that we want to transplant, but especially in polycystic kidney disease, it's particularly important. Now, this is a CT scan. It's actually cutting the body in half, front to back. And what you can see here are two very large polycystic kidneys. This is the left one, and this is the one on the right. And these are about 30 centimeters long. We would normally put a kidney in the bottom right or left-hand corner around here. Okay, that's one of the main blood vessels that we would be joining the kidney to. And in polycystic kidney disease, because the kidneys grow so large, we need to be very certain that there is enough space in the bottom left or right hand side of your tummy for us to be able to fit a kidney transplant into. So it's very important that not only do we examine, but quite often for my patients, I will get a CT scan just to look at the size and to see whether we think there's going to be enough space here. Because if there isn't, we may need to consider taking one or both of these kidneys out. We obviously also want to check the pulses because we want to make sure that you've got a good blood supply to the leg, because we'll be using part of that blood supply to perfuse the kidney. And we do a general examination of the heart and lungs. In terms of the investigations that we do the blood tests. We're checking for kidney function, your liver function, clotting, checking your blood levels to make sure that you've got adequate blood levels, any potential infections that you've got. We do cross-matching blood that help us match recipients to donors. And as I said, imaging of the native kidneys to assess for space. Fitness for transplant is incredibly important, and assessing that is incredibly important in making sure that you have a good recovery after transplant and benefit from the transplant. So we do an electrical reading of the heart initially, then we do an X-ray of the chest to check for any gross abnormalities. We'll do some heart scans, so an echo, which is a jelly scan of the heart. And if any of those show any potential abnormalities, or we think that you've got medical problems that may necessitate, we'll do further scans, such as an angiogram, which is a dye test of the heart, or an exercise test that looks more closely at your heart and your lungs. And we'll be guided by our anaesthetists and nephrologists to whether we think those are required. Now, there are largely two types of donor. There's deceased donors and live donors. Part of deceased donors, there's two other types. So donors after circulatory death and donors after brainstem death. The reason we define the two are that donors after circulatory death are slightly more unpredictable. So if you're called in and you're told that there's a donor, a DCD donor, they only proceed about 50% of the time. So it is possible that you come in for a transplant, but because it's a DCD donor, the donor is not proceeded, and therefore the transplant wouldn't go ahead. The donor after brainstem death, almost all proceed, and therefore you're a much higher chance of the transplant going ahead. Okay, and of course live donors are the gold standard. They give you the best possible outcomes after transplant, and we would push any potential recipient to find a live donor, but that's not always possible. So we revert to deceased donation in that case. So what happens at the time of getting the call? In Manchester, one of our recipient coordinators would call you. At different hospitals, it may be one of the transplant surgeons that calls you, but they'll ask you a variety of questions. And it's, is this your first call? Have you been in before? Have you had a previous transplant? Have you been well recently? Any coughs, colds, or infections? When did you last eat or drink? Can you make your way into the hospital? So a number of factors just to make sure that you are well enough for the transplant at the moment. Have there been any acute changes? And give you an idea of how quickly you need to make your way in. Quite often now we get 12 to 24 hours notice from the call to actually getting the organ ready for transplant. So it's not that you have to rush in, blue lights going, make your way into hospital. We often give you quite a bit of time. And it may be that you dialyse at your base unit if you're on dialysis before making your way into hospital, so that we don't have to do that on the transplant unit. But you will get this call and they will tend to be the first point of contact and give you all the information you need to make your way in safely. Once you make your way in, and again, it varies depending on which hospital you're at, but this is very general and most would follow this similar sort of procedure, but you'd be seen by the surgical team, the anaesthetic team and medical teams. They do blood tests and we would dialyse you if needed. Most places would do a chest X-ray and an ECG, and we'd await a cross-match report. And this is to confirm that you are compatible with your potential donor. Some of the time this can be done virtually, so there'd be no delay. Other times we'd have to wait for the organs to arrive before we can confirm that. So there may be a delay after the organs arrive. We then wait for the organ to arrive and always do a check to make sure that it is suitable for transplant. If at any point along this time there are problems or there are issues, we'd communicate that with you and just make you aware of that and discuss about whether you are happy to take on these risks that may have occurred or not. And as long as everything's okay, we'd get the patient to theatre. And this is where the photos of the operation come in. So if you are sensitive, then please look away and come back to us in about 10-15 minutes. If not, then we'll carry on. Okay, so the operation itself, if you look, the top left-hand corner is the head, the bottom right-hand corner is foot end. This is the tummy, and this is the midline here. We tend to put the kidney in on the bottom left or right-hand side of your tummy. This is a black line that would show where we make the cut. Now, your bowel and everything within your tummy is incorporated into a sac, essentially, like a thin film, which is called a sac. We call it a sac. And what we do is we go behind that sac to approach the blood vessels that go down the back of your tummy and down to your legs, because it's those blood vessels that we want to plumb the kidney into. This is an exposure of those blood vessels. So this would be the vein, and the vein carries blood back to the heart, and this is the artery, and this is the blood vessel that carries oxygenated blood to the kidney. So they're the two blood vessels that we want to identify, and we'd be putting the renal artery onto the artery and the renal vein onto the vein.
Hussein, can I just jump in?
Yeah, please do.
I'm not seeing your slides, and it may just be me. Is everybody?
Oh dear.
They're showing perfectly in front of me because I have to admit I'm half watching with my eyes half closed. I'm a sensitive soul.
Yeah, I can see them too.
Right.
Perfect. Thanks for that.
All right. As long as it's not me.
No, no.
Jane.
No,
I
look,
think
a
you've
few
seen the slides
yeah,
before.
lots of people can see them in the chat.
I think it's obviously me. Sorry about that.
That's all right. Thanks for flagging it up.
Yeah,
So this is the renal vein, so the vein that carries blood back to the heart going in. You can see that we've got 2 stitches at the end, and all we do is join the dots with stitches all around. And quite often, once we've done the vein, we'll do the artery. The artery can be much smaller, but that's the one that carries blood into the kidney. And if you just take a note of the kidney here, this is what the kidney looks like when it's not got any blood going through it. You can see it's quite white, very similar to the gloves that we're wearing. And when we've got blood going through it, when we've done the 2 joins and released the clamp, so there's blood going through it, it becomes this reddy, bright red color. And that's a sign of a successful transplant immediately on table. Even better, if you can, and it doesn't happen very often, but you see some urine coming out of the ureter. So that's the ureter that takes urine from the kidney to the bladder. And occasionally you do see fountains of urine coming out. And that, being a transplant surgeon, makes me very happy to know that things have gone very well in that immediate post-operative period, in that immediate intraoperative period. So once it's done, the operation takes about 3 to 4 hours. You're in the anaesthetic room for about an hour prior to that, and then in recovery for about 2 hours. And when you wake up in recovery, you're likely to have a mask with some oxygen on. In Manchester, we use something called a PCA, which is patient-controlled anaesthesia. And that's where you have a button attached to a syringe driver, and you press that button for some regular pain relief. You tend to have a drain in your tummy, which is a plastic tube that comes into your tummy. Hopefully not this much blood in it, but it drains excess fluid that's produced from around the kidney and just stops any collections forming from around the kidney. You'll have a urinary catheter, and that catheter goes into the bladder and drains off the urine, because that's a way that we can tell that the kidney is working once it starts producing urine, and it helps guide how much fluids to give you as well. In Manchester, most of our patients will have a line in their neck, and this allows us to give a lot of fluid very quickly should we need to. Also allows us to monitor your venous pressures, which helps us guide how much fluid to give you, and helps us give you drugs and take blood from you for the blood test that we need. There'll be lots of monitoring, and we'll be giving you some fluids as well. Okay. Most of our patients will go back to our regular transplant ward. Very rarely, patients may need to go to high dependency, depending on their other illnesses and how they've coped with the surgery. So you'd have daily blood tests. As I say, we look at your urine and your fluid monitoring. We do daily weights. That helps us guide how much fluid you've had and how much more you may or may not need. Everybody would be seen by a surgeon and a medical specialist on a ward round. We review the need for dialysis, and as I said before, one of the complications is delayed graft function, so a sleepy kidney. So if the kidney's not working immediately, then you may need dialysis. We review your pain, and it's an MDT input, so the multidisciplinary team. It's not just the doctors, the surgeons, it's also the specialist nurses, the ward staff, pharmacists, nutritionists if need be, physiotherapists and occupational therapists would all be involved if and when that's required. Time varies in terms of hospital stay. If everything goes really well, and certainly with live donors, we try and get patients home within about 4 or 5 days. With any complication, this just does delay you. So our average stay is probably closer to 10 days. The most common thing to keep patients in is delayed graft function. After discharge, there is regular outpatient follow-up. We see our patients twice a week in Manchester for the first month. After the first month, we space it out to once a week and then once every few weeks. If you are referred to us from an outlying centre, so centres further away, then we get you back to your local centres within about 2 to 3 months. And most transplant units will follow a similar sort of follow-up regime. In clinic, we do weight and blood pressure monitoring. We do blood tests, check your kidney function, urine tests, check for infections and protein and things like that. If need be, we look after any wound management. You'd see a doctor. and pharmacist if that's required. The clinic nurses and the team down in clinic are normally very, very good at giving general healthy lifestyle advice. You will see them for the life of your transplant. So we hope for many, many years, and they're the best possible port of call for any advice on holidays, on food, on travel, and prevention of other diseases. Finally, just a quick note. Lots of patients do want to write to their donor families after transplant. This is something that we really encourage. Polycystic Kidney Disease Charity has a section on their website that you can refer to. Most transplant centres will have advice or have someone you can speak to, and that will help you write a letter to the donor family if that's what you wish. So do consider it if and when you get a transplant. Okay. Thank you very much for that. It's very strange talking to a blank screen, so I hope it's been helpful, and I'm happy to answer any questions you've got. I'll stop sharing.
It was once again a fantastic and very informative presentation. I always find transplantation a fascinating subject, even as a family. We're now 11 years post-transplant, but it's something that it's just a fascinating topic. Some lovely questions coming in there. A few Jane and I have responded to. So there's a couple of things where we've maybe mentioned links. There's subject of nephrectomy, the removal of kidneys, has come up in the chat, and we know that it was a popular subject asked in advance. How common about removing kidneys? Are they removed? So can you put a little bit of light on that topic?
I'll talk about it in a bit more detail. So we try not to do any operations if they're not needed. So if you've got polycystic kidneys and they are not causing a problem and there is space for a transplant, we tend to leave them in. Reasons that we might take them out are if they are very, very big and there's no space for a transplant, or if they're causing you a problem. And that may mean recurrent infections, may mean bleeding. It may just be that they are so large. We've had some patients who haven't been able to get the nutrition in they've been able to, because they can't eat and drink because the kidneys are so large. So in those situations, we may take them out, or they may be causing such a big mass effect and they just become so heavy and you become so uncomfortable with them that we may decide to take them out. Now, prior to transplant, if you are still pre-dialysis during the workup, then we would really encourage to leave the kidneys in, because if we can transplant you prior to you going on dialysis, we know the outcomes are better. Once you go on dialysis, then our threshold for removing a kidney becomes lower because you're already on dialysis, and therefore removing one or both kidneys isn't going to affect you that much.
Thank you for that. And I will just say at the moment, I've popped into this chat, we have a fabulous recording available where we dedicate a full hour to just that whole topic. I'll share that link with all who've registered for tonight, because it is, again, a huge topic and it's one that we could go on about. Now, there's a few things have come up there in the chat. And again, the favourite, Catriona's asked it in the live chat tonight, and it's about the average weight. While someone else, unfortunately, we know an average is a centre point, and there's someone who's had a longer wait and is still in the list. So matching and allocation is something that we can, again, send a little recording link around tomorrow. But do you want to give us a nice, brief, kind of broad answer to those topics?
We say the average wait time is about 3 years. As you've alluded to, Susan, that there's a huge number of factors that vary, that can vary, and make that very, very short or much longer. I suppose the advantage nowadays for most patients, see that there's an advantage, is that the time is taken from, you start accruing points from start of dialysis, whereas previously it used to be start of activation on the transplant waiting list. Whereas now, if you are activated and you've been on dialysis for 5 years, well, those points will accrue from the 5 years that you've been on dialysis. So that's a relatively recent change in the listing criteria, but the average wait is about 3 years.
Yes.
There's a question about
that's super.
There's a question related to this about whether if you've had a previous blood transfusion, are you more likely to have a rejection? You're more likely to wait longer. In terms of wait times, if you've had a previous blood transfusion and you've developed antibodies, so antibodies are the cells that fight foreign objects, and you are prone to developing antibodies if you've had a blood transfusion, if you've had a transplant, or you've been pregnant. And if you have antibodies, it can be at that point more difficult to find a suitable match. Now, that doesn't mean that everybody who's had a blood transfusion will develop lots of antibodies. You actually have to have developed a huge number of antibodies to make it really significant for you to delay transplant. But some people can develop a lot of antibodies after one blood transfusion. Other people can have transfusions, transplants, and pregnancies, and actually have very, very low levels of antibodies. We've not been able to explain that disparity. We don't know why. Okay, so it's really dependent on the individual.
Yeah, a couple of different things about perhaps hurdles, or could it stop a transplant? Pericarditis. So does having pericarditis affect the ability to be transplanted?
It depends really on a number of things, but the cause of pericarditis is important, and your cardiac function. So if you've had pericarditis in the past and you've recovered and your cardiac function is reasonable, then it shouldn't stop you at all.
Yeah.
But that would be just assessing the cardiac function and the cause of pericarditis.
And you and I know that there's many of our community who've had surgical mesh repairs for hernia, and someone's asking if it's still possible to have a kidney transplant thereafter.
Yes, absolutely. Mesh repairs for hernias are very, very common, especially obviously in the polycystic kidney disease community. And yes, we transplant very commonly.
Jen, I imagine your eyes have been rolling up and down that chat as well there. Is there anything that's coming out to yourself?
They are. I'm kind of dizzy.
Oh, I know. Well, you're dizzy, and if you want to pick the next one out from there was a little one I know it was asked in advance, and it's come up again in the chat.
Yeah,
it was when you mentioned catheters. Do you have to have a catheter after transplant surgery?
Yes, without a doubt. Hopefully only for a short period. The catheter protects the joint that we make between the kidney and the bladder, so the ureter. Okay. What we don't want is, the bladder's a muscle, and when you use it and it fills up with urine, it expands, but that would put pressure on that joint that we make. So we want to minimize the pressure on the joint. Having a catheter just drains the urine, so that the catheter doesn't then explode, increase the size like a balloon.
Thank you so much for that, and hopefully that'll help the person understand why it's compulsory. It's part of. So, Jane, do you want to fire on with the next one, please?
Sure. There's the question here from Liz, and it's picking up the point, a question about points that you discussed earlier there, Hussein. Is there a maximum number of points you can have? She's been on the waiting list for almost 3 years and has accrued 616 points at this point. At this point last year, on HD dialysis currently.
No maximum, no. The points are relative. It's not so much that if you've got a huge number of points, you get to the top of the list. You're obviously close to the top of the list, but then the matching takes into consideration immunological matching as well. So the more points you have, the more likely you are to get offers. But with that, we have to consider who would be best matched to the donor based on immunology as well.
And again, that was someone else, I think it's Sam there, asking about the point system. It's always so difficult for ourselves to understand what happens behind the scenes at NHSBT when it's the allocation of these gold dust kidneys, and how it's all worked out in the algorithms and points and antibody matches, etc.
I think the reassuring thing that I have about it is that it's done by an algorithm that looks at things very objectively. and looks to find the best recipient for the donor that we've got. So it's not somebody picking names out of a hat. It is done very, very objectively to ensure that these resources are used in the best possible way and to get as many people as possible to transplant.
Yes, and someone's asked in the chat there, is the point system the same across the nation, which I assume to be England, but I will broaden it out to say all 4 nations. There'll be no, it'll just be the same system across all 4 nations for allocation.
It is, yes.
Yeah.
There's a question here. Somebody mentioned earlier on in the chat about artificial kidneys, and there's a pre-event question here around genetically modified pig kidneys, which of course is the sort of hot topic at the moment. We've got the longest surviving pig kidney recipient in the US. I think they are still alive about 4 months in. Do you have any thoughts on that, on how quickly that might advance and be rolled out into the market?
So I'd love it to come in tomorrow, because it would make my job a 9-to-5 job, and I could choose the kidneys and get them arrive and implant during the day. It's incredibly promising, but I think we're a long, long way away from them becoming reality for the masses. I wouldn't even be able to guess at a time scale, but many, many years, I think.
And I'll say the question we all expect to come up, and it's only a matter of who'll ask, will the new kidney develop PKD cysts?
Yeah. No, it won't. No, it's resistant to, because it's a genetic disease, so it's resistant to that, because it's got a different genetic code.
Yeah. And someone's asking, while they're having a transplant, would you remove their PD catheter, or is that a separate situation?
Interesting question. Sometimes we do, sometimes we don't. It can be really variable, partly on the surgeon that you've got, partly on whether actually we think it's going to be a sleepy kidney. And if we think it's going to be a sleepy kidney and you may need dialysis, we may leave the PD catheter in, because we can continue to dialyze you with that after the transplant, just for a short period if you need it.
Fantastic.
I do have another question. It's not been asked in the chat, but it did come up in a conversation I had today, which was, why does the call for a transplant typically come either very late at night, in the middle of the night, or in the very early hours of the morning?
Yeah.
I kind of know the answer, but maybe you could talk about that.
Yeah, it seems to be a quirk of transplant. Most of the offers tend to come in the middle of the night, or tend to come late at night. Most of the retrievals tend to happen at late at night as well. That side of things tends to happen late at night, so that ideally the implant can then happen the next day during the day, because it's a 24-hour cycle. This essentially we see. So ideally what we want to see are patients coming in with 12 hours to go at least before your transplant, which gives us enough time to do the blood work, to do any investigations, to get seen by the appropriate people. And that sort of planning is done from the offer stage. So most of the offers come in evening or overnight, so we can get the patients in and then ready to implant the next day.
Now I'm going to give, you can see, the 8-minute warning, because there's lots coming in here. If anyone has any pressing questions, I would suggest they get them into the chat just now, because we will be finishing at 7:30. We touched on the long-term impact of living post-transplant, living with a new kidney, and something that's here Tamara's asked about, the main sources of infection post-transplant when you are immune suppressed.
Yep.
And today, as a PKD wife and transplant patient wife, I did have to phone the renal department because our grandson has chickenpox this morning. And of course, I was with him all weekend, and the little darling was here last night. But aside from myself, it is a lovely question that Tamara had sent in advance. What are those main sources of infection when we are immune suppressed?
Okay, so there's a number of ways of looking at infection, I think, post-transplant. And those, I tend to divide it up into infections that would affect anybody who's not had a transplant. So myself, for example, and transplant recipients are prone to those infections, obviously, okay, just as anybody is, like the flu, like an infection in your bowel or gallbladder or anything like that. But transplant recipients tend to suffer worse with them because of the reduced immune suppression. Okay. And then there are those specific to patients who are on anti-rejection medicines, and they tend to be a group of viruses. And some of you may have heard of them, but things like CMV or EBV, these are viruses that specifically affect patients whose immune systems are not working optimally. And those infections can range from being present in the blood that we would monitor in clinic and really just not have to worry about and just make sure that there's nothing going on, through to potentially making you very, very sick, needing hospital treatment and admission. How everyone reacts to these is quite different. At the time of transplant, we assess the donors and the recipients as to whether you are carriers of these diseases already, because a lot of us, for example, will carry CMV or EBV with us, and you may 80% of the population has EBV carrying in them. Okay, so it's about whether after a transplant, is this making you unwell? And that's what we monitor. And if so, what treatment can we give? Some of the medicines that we start at the time of transplant are designed to minimize infections from, say, for example, CMV within the first 3 to 6 months after transplant, because that's when we know you're most prone to these things developing and causing a problem.
And Susan, I know we're on the 5-minute warning. There's a couple of good ones here. I mean, this does come up a lot, doesn't it? What happens to the size of your PKD kidneys if they remain post-transplant? Do they shrink or do they grow?
I meant to answer that. Apologies. They tend to stay around the same. Sometimes I think they get a bit bigger. They tend not to shrink, actually, because the kidney is just made up of fluid and cysts, and those cysts tend to remain. So they tend not to. Occasionally, we do see them get a bit bigger, but I think that's just the natural progression of the kidney rather than the fact that you've had a transplant.
So the native kidneys remain plumbed in, so to speak.
Yeah, I saw a question actually talking about the native kidneys. We leave the kidneys in at the time of transplant, essentially because we don't need to take them out, because where the anatomy of the transplant is unrelated to your anatomy of the actual kidney. So if we don't need to take them out, then we don't at the time of transplant. If they don't cause a problem once you've had a transplant, we would leave well alone. We wouldn't put you through an operation you don't need.
Something that many people as a population are concerned about is our BMIs. And Janet's been brave enough to ask the question, what BMI do you need to have to be listed on the transplants?
Okay. There's no actual national consensus. Units tend to have their own guidance. I think in Manchester, we push the boundaries more than other units, and our BMI absolute cutoff is 40. So anyone above 40 wouldn't be eligible. We do say that between 35 and 40, it's taken on a case-by-case basis.
Yeah.
We would assess the patients and check that they are quite, transplantable, whether we are able to get a kidney transplant in. Sometimes patients who are BMI between 35 40, we may just feel it's not possible to get a kidney transplant in them. It doesn't happen very often, actually. So our cutoff is 40. Saying that, the lower the BMI you can get, the better the outcomes are. And we know that above 30, actually, the complications after a transplant are slightly higher. Above 35, they're quite a bit higher. And those complications tend to be wound related, so wound infections, hernias, open wounds and collections and things like that. And that's what we try and avoid by limiting BMI.
I'm going to pick one last one, and Jane, do you want to kind of have a look there and pick a couple maybe? I've got someone saying it's
I picked one. Maybe we've picked the same one.
Well, we'll see what we've got. Right. We know in the regime of medications post-transplant, one of the treatments is prednisolone, which is a steroid. What is the chances of a patient coming off that further down the line? So it's not long term, perhaps just a shorter period of time.
Interesting question. This again largely dependent on the unit that you are at and their immunosuppression protocol. I think most units in the UK now, they use what's called a steroid sparing or steroid minimizing protocol. So in Manchester, we would give prednisolone for 5 days and then stop it. So you'd then only be on something called Adaport or tacrolimus, there's a couple of words for it, or MMF and MMF. So we use those two, and we use prednisolone just for 5 days and then tend to stop it as long as everything else is okay. Our exceptions are if you've had multiple transplants, we would continue a small dose of prednisolone, but most patients would stop that after 5 days. And that tends to be the pattern in most transplant units in the country.
Thank you. Jane, I don't know if we had a matching question or if you've got another one there.
No, we didn't. I was just sort of keen to give Jonathan an answer to his question, which is, can you insist on having a double nephrectomy? He's 8 weeks post-transplant, so I'm assuming he's struggling a little.
You can, I mean, you can do. I think it needs justifying in that if you are getting symptoms, then it's perfectly reasonable to have your kidneys removed. But I think 8 weeks is probably too early. I think it would depend on how you're doing, but I would normally, personally, I'd probably wait 3 months before considering it and then going ahead. A double nephrectomy is a larger operation than a transplant. So I think you have to be ready and fully prepared that is not a small undertaking at all. In terms of taking both kidneys out, the way I approach it is because it's a big operation, I always say to my patients, we'll aim to take one out and we choose one, whichever one's causing more problems. We'll choose that and do that first. And if you are well and stable, because occasionally you can become quite unstable, and this tends to be an anesthetic call actually, is the anaesthetist become worried because we're taking a big kidney out. There's often a bit of blood loss. So if there are concerns, we wouldn't proceed and take the other kidney out. We may come back another day, but it's about getting you through that operation at that time. So I'd never guarantee that we take out both kidneys at the same time.
And on the topic of these big kidneys and bigger operations, because they're big, someone's asked if the sheer size of our kidneys, the impact it has in their BMI, because we know, and we have published stories of the whoppers that come out and the weight that can be involved in those. But would it really impact in someone's BMI for listing, or is it a discussion one-to-one for their team?
I think it's a discussion one-to-one for their team. I think we would certainly take that into consideration. But if you've got a BMI greater than 40, then it's not just the kidneys that are going to be causing that large BMI. But it would be a discussion, of course.
Yeah, that's lovely. And that is us just running slightly over. So
can I just jump in with one more question? What's the absolute limit on ischemic time, sort of time donated kidney outside of the body before it's transplanted? The absolute limit.
Yeah,
say no.
Anything, there's no absolute. We would be very hesitant beyond about 24, 30 hours. But a lot depends on the donor and the quality of the donor that we've got. So, for example, if you've got a 20-year-old donor, then we know that kidney will give you very good function, even if it's been out for 24 hours. However, if you've got a donor who is 70 and perhaps has a history of high blood pressure, then we would want to get that kidney in much quicker. And our limit, depending on the surgeon, would probably be in the region of 18-ish hours, but with a real push to get it in as quickly as possible.